Good morning, everybody. Thank you for making it so lively in the morning. For the next session, we are talking about ALK positive non-small cell lung cancer. The moderator for this panel discussion is none other than the main organizer for this OBTO, Dr. Amish Vora. May I invite you to please come over? And may I invite the chairperson and the panelists to come here, Dr. Rakesh Chopra, Dr. Ullas Batra, Dr. Suman Gupta, and who's the fourth? And Dr. Sailesh Podnar.
Invite our chairperson, Dr. Rakesh Chopra, to give a small, introduction to the topic.
Good morning, friends. It's nice to see an almost full house in the morning at 9:30 in Delhi on a winter morning. The topic for today, the panel discussion, would be moderated by Dr. Amish Vora. And I just thought I'd just give you a little amble. I know you all know all this, but I just thought I'd give you a little preamble to the subject which will be discussed in the next half an hour, 45 minutes. Oops.
Next slide.
Yeah. According to the Globocan 220, the lung cancer incidence in India is the fourth most common cancer diagnosed in India. So I think we all, as oncologists, need to take this seriously. And although we catch the animal by the tail, but actually it's the screening which is most important for all of us. The lung cancer with distant metastases in males is 44%, and in females is 47.6%. The estimated number of cases from 220 to 240 in both sexes in the age group of 0 to 85 years is 72.5K in 2020, and is likely to rise or almost double in 2040 to 120K. The estimated death rate is 7.8% of all the cancer-related deaths, and as you see here, the ALK rearrangement in lung adenocarcinomas is the second most common and targetable genomic change after the EGFR mutation, and constitutes about 7.9% of the pie of adenocarcinoma's lung. This is the development timelines that has happened in the EML4 ALK space, translocation space, from 2007, when this was discovered. The translocation of EML4 ALK translocation was discovered, and in 2012 they came out with the first drug, that was crizotinib. It was the first generation ALK approved inhibitor. 2015, the second generation, that is ceritinib, alectinib, and brigatinib, were approved between 2015 and 17. That was the second generation. And then what is the subject of the talk this morning is the third generation drug, lorlatinib, and this was approved in 2021. The question is whether this should be brought from the third and second line space to the first line in. So may I present to you the entire panel? You all know them, and Amish to take over the dais. Thank you.
Thank you. So topic is ALK positive advanced non-small cell lung cancer. Since Rakesh sir has already given the introduction, I'll straight away start. So 54-year-old female, there are no comorbidities. Since 1 month has cough, slowly growing into breathlessness. almost to the tune of orthopnea. She was, not able to sleep straight because of cough and breathlessness. She had a weight loss of 10 kg. So detailed investigation was done. By the time she came to me, this was the PET scan. Biopsy showed adenocarcinoma. Lung panel was sent, but patient was very symptomatic, and as a result, I talked to patient and I told, the name is written because I have taken the consent from the patient. I told patient that we will give the first cycle of chemotherapy, and once the lung panel comes, we can modify the treatment. So patient was admitted in my daycare. We had mixed the chemotherapy drug, and Dr. Jay Mehta from Bombay called me कि Amish ALK positive है. So now what to do? So जब भी ऐसा होता है, I call Dr. Ullas Batra. There is a medical oncologist in Delhi. He practices, I think, in Rajiv Gandhi, if I am not mistaken. So he said, Dr. Vora, कुछ भी मत करो, सीधा lorlatinib शुरू करो. I said, यार ड्रग मैंने मिक्स कर दिया है, and a patient is symptomatic. No, there is nothing wrong. We are talking of science here. I was little worried because, my experience with lorlatinib was not very high. I was using a lot of alectinibs earlier. So I called Dr. Kumar Prabhash also. And Kumar said, कि Amish, lorlatinib, you will get a very fast response with that. So we started the patient on 100 milligram of lorlatinib. 2 weeks, she started improving. Her disease-related symptom actually started slowly going down. And I was thanking both of them for giving me the right decision, because otherwise I would have given chemotherapy to this patient. Oral drug did wonders for her. At the same time, there was peripheral edema and weight gain. 1 month later, patient started complaining of peripheral neuropathy. She was doing banking work. She kept telling me that she kept forgetting things. 2 months later, disease-related symptoms were almost completely gone. But neuropathy troubled her, and she was not able to hold glass in her hand also. There was a brain fogging and not able to concentrate. So let me start with Sumant. Sumant, what will you do here?
So basically, we all know that lorlatinib being a very effective drug, but it has these problems with hyperphagia, hypertriglycerides.
She was started on atorvastatin upfront only.
Yes, and or brain neuropathic symptoms. So we have got a very good response. I think we'll continue the drug and see for the side effects, and maybe have some percentage reduction in the drug dosing upfront.
Shailesh?
Yeah, I mean, was the MRI? I mean, it must have been done.
Sorry?
Hopefully. MRI of the brain.
MRI of the brain done. ALK positive, normally you will do MRI of the brain. Yeah.
So I think dose reduction is an option, and let's switch down to 75 and see whether the symptoms continue to be there or they disappear or reduce.
Okay. Ullas?
Stop drug for 2-3 days and then restart at 75 milligram per day once the symptoms recover.
So that Ullas said very interesting thing. I stopped the drug because patient said, sir, pak gayi hu main. Actually, genuinely you could make out that on one side we had a drug which almost nearly symptoms disappeared for lung cancer. On the other side, she said, sir, I can't handle. So when I stopped for 3 to 4 days, 4th day she called me and she said, sir, this was her exact words, sir, thoda zindagi jeene ka maja aa raha hai. And I was really wondering. I said, ye kya chal raha hai karke. On one side, the drug is working well. So I called them and I reduced the lorlatinib dose to 75 milligram. Her brain fogging reduced. She was able to concentrate better. Neuropathy was still on. We have started doing the exercise program for the small muscles, and we are getting good results. I am collecting the data. Very soon we'll present that. Hand and leg edema was still on. She was very troubled with the hand edema. So we decided to do PET CT early on rather than later, and this was actually the difference in the PET scan. This was something, just 3 months of lorlatinib, 100 mg, then 75 mg reduced doses. This was something, phenomenal. So, this brings to our first point of efficacy of lorlatinib and the crown data what we have. So 18 months data and 36 months data, Ullas.
So prior to that, I mean, let us look at how the lorlatinib 100 mg dose was achieved. I mean, so yes. Yeah. Correct. So I mean, so that trial is not yet there. But I mean, so my point is the 100 mg dose was established because you were looking at a ALK resistant mutations. Right, this drug was tried when you have given alectinib, ceritinib, prazotinib, and then patients had developed mutations. Most of them were ALK resistance mutation. To counter this mutation, 100 mg dose was found. This dose at 100 mg at resistance is totally different from the dose that you start with. So what I do is, in the absence of our data and to prevent medico-legally, I start at 100 mg per day, but I'm absolutely okay if the patient has any side effect to reduce the drug to 75. A lot of people have got, in my practice, 75, and there's a doctor who did develop some symptoms who is now on 50 mg per day also, which is okay. Why I don't start at 50, 75 is because there is no long-term data. Tomorrow, after 5 years, if you start at 75 or 50 and you find out, that the efficacy was lesser, I will not be able to, forgive myself. So start at 100 and the brain. You also require, you probably require more good this thing for 100 mg for brain. So start with 100 mg, come down to 75 mg if the issue is. The second point is, let's not make it, very few people, I have given lorlatinib to a lot of people. These kind of people, that people will go mad when you turn them into lorlatinib or something, and neuropathy, not able to hold classes. This occurs in very minuscule people.
What percentage?
Less than 10%.
Okay.
Normally,
Unfortunately, both of my first two patients had the similar kind of side effects.
When immunotherapy came, the word was divided into people in which it worked wonders and in people in which just didn't work. So I think when you do it over a long period of time, you will realize it doesn't really have a difference.
So 10% of the patients have less than 10%.
Grade 3 event.
Grade 3
1,
event.
grade
Okay,
2 is
perfect.
Grade
So
3 is an issue.
point well taken. Shailesh, there is a crown data what we have. We have been seeing the LX data, based on the LX data and the crown data. I'll just present 2-3 slides. So the crown primary endpoint 36 months data, we have that. And patients without brain metastasis and with baseline brain metastasis, the hazard ratio is exactly similar. 0.21 and 0.29, there was not much of a difference. And this is a famous PFS projection for lorlatinib. I remember TMH Varanasi, Senthil was telling me कि इससे अच्छा क्या हो सकता है, when I was talking about alectinib still holding ground. So this is the projection of lorlatinib, and this is the famous slide based on which I think this one slide made people change that CNS का अगर कुछ भी है तो lorlatinib should be the first. But if you see this is without brain metastasis. 1 out of 112 patients without baseline brain metastasis exhibited intracranial progression on lorlatinib. Now this is something which is actually very good. With brain metastasis, there is a complete response of 72%, and we know that it is better. On the other side, alectinib, the primary endpoint, nearly 3 years freedom from progression what we have. This is the only, alectinib is the only drug where we have a 5-year OS data, and still the median OS has not been reached here. And this is famous Asian when we talk of. And LX and crown, if we see Asian data, the hazard ratio is 0.46, and in crown, hazard ratio for Asian patients is 0.47. Sumant, you, before this panel, we were talking of this Asian data. So this is sort of an Asian data, but if you see overall, LX and crown, lorlatinib hazard ratio is 0.27, and the hazard ratio of LX still is 0.47.5. Do you dissect out Asian data when you practice?
So see, dissecting out a data is different, but when you have a strong, my personally would be that if a patient has been upfront with a ALK positive, why not a Asian patient, a local patient? Why to go for a second line drug when we have a first line? Although the data is excellent, I'll not say that there's any flaw with the LORLA data. LORLA data looks like a dream data to us. But again, alectinib in a Asian patient with no brain mets upfront, I still will be tempted to dissect out this and to say that at least in we have to do subgrouping where we should think about LORLA and where we should think about alectinib, not a blanket LORLA thing.
Okay, so without brain metastasis, this particular patient in your practice, you would have started with alectinib. Okay, Ullas, you told me to start lorlatinib. I started lorlatinib. Shailesh, you are sandwiched in between the two. What do you do in your practice?
So, you know, the slide which you showed without brain metastasis, you, I think, probably didn't show the HR. It was, you know, this one. So it's 0.02. It's 0.02. HR is.
But see, remember this, the primary endpoint on this slide is different. Intracranial time to progression. It is not the overall PFS. Systemic and brain. This is only brain.
Yeah, fine. So basically, you know, one of the main issue is always brain metastasis in this patient. So, you know, the quality of life and everything without a brain metastasis is going to be phenomenal. So I have no second thoughts on putting this patient on lorlatinib for PFS also and for intracranial events as well.
Okay, perfect. Chopra sir.
You know, first of all, lorlatinib is a drug which is very close to my heart. First, I was the first person in this country to use lorlatinib on a compassionate basis. So that's one. Second, I've had outstanding results with lorlatinib, and I find it very easy to handle. I never got any brain fogging in any patient of mine. I never got neuropathy in any patients of mine. So I am sort of sold on lorlatinib, and I would have used lorlatinib in my...
So, Ullas, since you have all the data at the tip of your tongue, I want to ask you, what is the response rate of lorlatinib and alectinib?
So the response rate in lorlatinib is to the tune of around 85 to, I mean, our own data you're asking around, I mean, I have hardly seen one patient who did not respond to lorlatinib, died in 3 months time, 4 months time. That is one, that is all that I remember. Alectinib also, the response rate is good, but it's the PFS, it's the magnitude of the benefit that you get. If you have an agent which has got fantastic intracranial activity, increased PFS, I mean, what more do you want, as you said, you know? I mean, why, if you have a Virat Kohli, why will you want to look at Shreyas Iyer?
Shreyas Iyer sometimes can score triple century
and
also.
Has been dropped out and has been sometimes.
I think the response rate of alectinib is marginally better than lorlatinib.
Correct, absolutely. So, Sumant.
So again,
Cross trial comparisons.
एक minute. Ullas wants to compare Rajiv Gandhi data with Crown data. That is allowed, but he can't do the cross comparison also.
Sir, one more thing. Just playing the devil's advocate. This lorlatinib data where 112 patients were studied and only 1% conversion. We do not have a similar data for that. Okay, so if we see the basis of both the trials, the alectinib trials and that, the upfront number of brain mets or upfront number of non-brain mets, those subgroup have not been studied in alectinib. So you have a very beautiful slide which shows that only 1% will shift, will have a brain progression.
I said that is the most famous slide of lorlatinib,
so
and I have been seeing for last 1 year.
Yes, looks lovely, and with that slide you feel that your brain mets are cured. Out of 112 brain mets, only one brain met progressed.
Senthil, pick up a mic.
Amish,
Senthil, pick up a mic.
It is out of 112 patients, only one developed who did not have brain. So that's not 1% of that. Yeah.
So, Senthil, point is lorlatinib, alectinib, have you switched your practice? All patients upfront lorlatinib? Okay. Amol?
If possible, yes.
If possible, yes. Ashish? If possible, yes. Okay, perfect. Suman, you are the lone warrior here.
Listen, Amish, what are we doing with this drug? Why are we giving this drug? Let's ask ourselves this question.
Which drug?
Lorlatinib or alectinib or whatever. Why are we giving this drug?
Sir, Ullas tells me to give, so I give that.
No, we are giving this because what is going to kill this patient is the CNS disease. And that's where your
Sir, I don't agree with all of you. Basically, we are looking at something, and I'll tell you why I'm saying that. But Govind Babu, sir, Asian data. No, I'm not talking of. Do you believe in this slide, sir? The slide which I have projected, the Asian data, subset analysis, LX and Crown, we have the ratio here. And this shows that alectinib is 0.46, lorlatinib is 0.47 in Asian population. When the Flora first came, you remember the G.S. Bhattacharya sir, we miss him a lot. He was the one who said, Amish, this does not work. Osimertinib does not work so well in Asians. Remember that. Then we have Flora 2. So Flora was on the lower side. Everybody accepted, yes, osimertinib is very good drug. Similarly, alectinib and lorlatinib, 0.46, 0.47. Do you believe in this slide, sir, or it is too much of a dissection of a data?
As of now, I think it's too much of a dissection, but this is the only data that you have. So you have to go by it till you have something else.
Okay.
So Amish,
So the only point, I want to raise a point, that what are you going to do after Lorla? If your thinking is that, then probably there is some rationale of giving Alex first. Somebody said Virat Kohli has to bat first, but then if he gets out, who's going to bat next?
I'll tell
So
you
unless and until you have Dhoni batting behind him, you cannot win the World Cup.
So just because you have not given chances to Dhoni, that doesn't mean that Dhoni can't bat, right? So the point is, after lorlatinib, so we also have certain data, and I've been interacting with people. You do a biopsy, again do a liquid biopsy, you have I think 20% chance of a MET amplification you can do. You also have you do a biopsy and do other things. People have also in the Crown trial tried the post-progression this, and people have actually tried the second generation others also, which are working. So it's not that it doesn't work. And again, if you see if you give alectinib in the lorlatinib trial, after lorlatinib, the median PFS is 6.8 months. So you have a fantastic drug which has a great PFS, great interconnect activity. I think it's more important to we start better first.
Okay, fine. I just wanted to remind myself, of course I can't do that to Ullas, but I wanted to remind myself that ALK is the only non-small cell lung cancer, stage 4 if you take it, is a forgiving disease. There are, I have used that slide so many times today, I decided not to use. Whether you use crizotinib first or whether you use lorlatinib first, on an average, ALK positive patients survive for 7 years and above. That is majority of the patient do that, except for your patient who died in 3 months' time.
Tata Memorial data says if you start on crizotinib, people are living for 40 months and 42 months, the real one. So again, it's just because it's a forgiving disease, which you say, to me, ALK is a very, any cancer is an unforgiving disease. You get brain meds,
so,
and forget if you get
Ullas, I'll tell you one thing, how I look at it myself, if I have to sort of, look at it, if I suffer today from ALK positive disease, if somebody is working for 14 hours and for 5 years on lorlatinib, and we'll just see that we have 11 more minutes. For 5 years, if my brain is going to be fogged.
Amish,
one minute.
So
and we will come to that, why I'm saying so. Okay. So this particular patient, on the day of PET CT, she said, "Ab sahan nahi hota, sir. Can we go back to chemotherapy?" That was her. No, I didn't give, but I was about to give. So this is the famous slide of lorlatinib, where they say that with the time, the CNS side effects, go down. And if I see all the boxes, she had all the boxes. The second patient I gave lorlatinib had only brain fogging. None of the neuropathies or anything was there. Her cholesterol was little higher, but atorvastatin was given. My point is, grade 1 and grade 2 CNS side effects, how much does it matter in our decision making in a patient, say a 50-year-old, prime in his or her career, and doing that? See, there is no doubt about the lorlatinib data, efficacy data. I think all of us are sold to that. Point is about this. So let Shailesh.
So I think this patient actually doesn't look a real patient, frankly speaking.
अरे मेरा है यार.
I am not saying that. This looks, one patient having all the side effects of the drug. It's something
मैं
which
चार्ट भेजता हूँ कल यार.
something which is unrealistic. But unfortunately, she had all these issues because the patients I treated, I mean, not a big number, but one or two is fine. I mean, but it does matter. I mean, with a CNS problem with such an extent, I think dose reduction, but never, I will not think of putting this patient on chemotherapy. We can still go down further to 50 milligram and continue with this.
I think I totally agree with Dr. Shailesh. The idea is to manage the toxicity profile. And I'm sold out now on
So I think let's discuss that. I think the side effects of lorlatinib. Yes, please. Bolo.
Yes, finally, see, if you don't kill me, he will.
Updated OS on lorlatinib post the initial publication.
नहीं अभी नहीं आया.
So no, I'm talking of the curves do tell us a story which I think I second Dr. Amish. That you catch up. If you look at the hazards for the initial NEGM publication for the PFS and the OS, you have the curves very different. So what does the house have to say on? Just if you have the OS curves. That is not OS curve. That is PFS. No, if you have the OS curves also.
No, OS curve, I showed it to alectinib, 5-year OS data.
No, you do have the crown OS curves.
No, it is the same 0.29. Same 0.2.
It is not abhi come in as a mature OS data. Okay.
Amish,
Let me tell you.
Digressing a little bit, how many people have taken atorvastatin in this room?
What?
Atorvastatin. It is one of the most crippling. It's one of the most crippling drugs if a person has taken it. And I have personal experience. My wife has the personal. We literally, went to the rheumatologist and all kinds of things because it was so bad we couldn't even get up from the bed. It's easy to say atorvastatin de do, 4 milligram de do, ye de do, wo de do. But believe me, I'm telling you, it can be very, very troublesome to a patient. To a lot of patients, and a lot of patients drop out of atorvastatin treatment. Just digressing a little bit from the side.
I think Amish needs a little bit of help, and I will support Amish. And Rakesh, I've been taking atorvastatin for the past 3 years, and I'm sitting in front of you, 0 side effects. So you had a problem, I don't have a problem. So there is an individual pharmacodynamics, kinetics happening. I have used lorlatinib in 2 patients, and both of them had such a horrible time with CNS side effects that one patient is on 25 milligrams and one patient had to stop. So it's not an easy drug to
So
tolerate.
2 plus 2, 4. 2 plus 2, 4.
I don't have 50 patients like Ullas.
One common patient.
And one more thing, one point I want to make, when we are frightened of side effects of drugs, whatever the targeted agent may be, I would agree with Ullas, start with the recommended dose and go down if there is toxicity other than the other way around.
And please also remember all these horrifying side effects that we talk about did occur in patients who are, this is basically from the second line. Patients who had got radiation before, patients who had got, other agents before. So these were not the first Crown trial data. Again, 2 patients, 3 patients is there. When you started upfront over there, it's not that bad drug to start. And again, as a matter of fact, please don't give atorvastatin, give rosuvastatin. Atorvastatin is not, it's got connections with lorlatinib. It's a rosuvastatin that we should be.
Okay, perfect. Sumant, intracranial safety data is here, and according to the house, how I look at it is that people are saying that it's not a major issue about the side effects of lorlatinib. Your personal experience of...
Only one patient, I did not have much. So I have not used lorla much, sir. So I think it goes back. See, basically, if it is lung cancer, whether you start, like you asked Ullas sir before, most of the patients reach him only. So let him give this.
No, Shailesh.
So, just one second, one more. Having said great things about lorlatinib, we are going to publish our 5-year survival data of alectinib also. And our alectinib data of around 50 patients in the first line also is showing great 40-45 months of survival till now. So, it's not that it is a bad drug, it's a good drug, but I mean, I would probably suggest today lorlatinib is a slightly
better.
better.
No,
But
absolutely.
I'm absolutely okay if somebody wants to give alectinib. That's
No,
what I'm-
absolutely, you are right. My point is, do we have the guidelines to reduce the dose of lorlatinib?
Yes, we have.
Okay, so Ullas,
Yes.
can you just share that?
You will show it the next slide. I mean, in the next.
No,
in
next
the
slide is this
in
is
the
what
next
I'm
one, this
showing.
one. This one, in the next one, you will show that if you reduce the dose of lorlatinib, it doesn't really change anything, and the efficacy is absolutely same.
No, you said that you start with 100, and at the slightest of the hint, you drop down to 75.
Yes.
So I want to know what are those hints where you
By
reduce
and
the
large,
dose.
There are 3 side effects that we see. One is hypercholesterolemia, I mean, which will happen in almost everyone. By 15 day, we do lipid profile. I do start them on rosuvastatin 10 mg at that time. If it doesn't, go to 20. If it is not, then add the F drug over there. This is one. CNS side effects is one where I do reduce the dose. If somebody, I mean, if you look at the CTC grade 3, you have to stop and then reduce to this.
Yeah.
So at any CNS, because one of my patients who was a young doctor, in fact, had a lot of, he was not able to concentrate on surgery and do. So in that, we reduced to 75, doing absolutely fantastic.
Okay.
Third is weight gain. Weight gain happens continuously over the time after 3-4 months, and if after giving diuretics it doesn't respond, we can actually reduce the dose to 75 at that.
Okay, Shailesh.
I think it is very important to have a joint discussion, because invariably what happens is this patient go to the radiation department and get radiated. So, it does happen. Invariably, from a pulmonologist, the patient is referred directly to the radiotherapy department, and it can happen unless the team discusses it and says that, well, let's wait for the reports. Invariably it happens that we are in a hurry to start the treatment. So one of the option is, to get an IHC done first fast, so that the reports are available immediately, instead of waiting for the NGS,
yeah.
and then, thinking of doing what is to be done. So that is important, because otherwise then it becomes a troublesome issue to put the patient on lorlatinib.
Okay, before Ullas, you say that, Senthil, this slide, side effects profile of alectinib and lorlatinib, you have used both the drugs, I assume, in good capacity. In terms of just the side effect profile, what would you say?
Just in terms of side effect profile, lorlatinib has got more side effects than alectinib. But as everybody is saying, we've seen all the dirty TKIs, right? So we've learned to manage all the dirty stuff that the TKIs produce. So the same thing will hold good for a drug like this, because you see that the numbers are vastly superior. So if it's vastly superior, you don't want to deny it for the sake of a side effect. One addition to what Ullas was saying is, I think you should learn to spot these side effects. They actually happen in a chronological order. So you should know when what is likely to happen. Educate your patient, educate yourself, so that you're picking up the side effects on time and then treating them. Because it's important to keep your patient on the drug so that you get the desired outcome.
Right. So, Ullas, this slide made drug discontinuation due to AE. I see more alectinibs than lorlatinib here.
Again, I was about to say, alectinib has a lot of liver dysfunction, lot of creatinine dysfunctions. People should test for it. I mean, normally people don't do a blood test or do a LFT and KFT also. No, I have seen. Anyway, so yes, but it's clinical trial setting. I mean, in that you are very skeptical. Just one last comment which Dr. Shailesh said. IHC picks up more than what an NGS picks up. I mean, we are doing both IHC and NGS. Something because the NGS is not done by RNA at other places, and the known fusions, unknown fusions may not be detected. So IHC is absolutely okay. Please test for IHC and don't only rely on NG.
Right. So, Ullas, assuming this patient does not wish to continue lorlatinib because of the side effect, what would you do?
So not doesn't make you don't want to reduce 75.
No,
50?
75 kar diya, 50 ka bhi bola, but the patient said I have 2 years of working and I want to be.
She has taken it for 3 months.
3.5 months, yes. No, if she doesn't want to, she doesn't wish to continue.
Go to alectinib then.
You go to alectinib.
I will not give chemo, if that is what you are saying.
No, I'm not asking you anything.
I mean, I will not go to chemo, I'll give alectinib, or then I'll ask her alectinib, serotinib, whatever she wants, alectinib.
Yeah, so in the interest of time, Shailesh and Sumant and Chopra sir, last line, if patient does not wish to continue lorlatinib, what would you do? Go to alectinib?
Yes.
Go to alectinib. Sumant, Dr. Chopra. Okay. I think, conclusion mein, what I wanted to discuss in this half an hour was the data of lorlatinib is definitely superior to any other TKI we have right now. It should be the drug of first choice, but the side effect recognition is very important. I personally think is grade 1 and grade 2 CNS side effects still matter in a day-to-day life. We should not forget that. Nilesh is nodding his head, he's nodding his head. That is something we ignore. In a pool of patients where Rajiv Gandhi or AIMS versus, 1-2 patients in my clinic, they matter a lot to me, how they behave in day-to-day life. Yes, as Senthil said, we should learn how to manage those side effects, but sometimes if those side effects are unbearable to the patient, we should not, we have another drug, another TKI with us.
One point. I think very important thing what Senthil said was that, spot these things very early. I do talk to the patient separately, and after the patient goes out of the room, I talk to the attendant separately, yaar, inka mood change hua ki nahi hua, because everything rest I can see. So I do talk to the patient and educate them upfront that these 3 side effects are there. If you get anyone, please come back and tell me.
Our time is up. Chopra sir, last sentence and then we conclude.
See, after all, the main aim of us medical oncologists is to try and reduce the toxicity and get the maximum benefit. So, with all these new treatments, whether it's immunotherapy, whether it's targeted therapy, we are going away from chemotherapy towards this. So, one has to hold back chemotherapy as far as possible in this patient.
Absolutely.
Unless you are absolutely pushed to the wall.
True, agreed. Thank you so much. Thank you all the panelists, and thank you for patient listening. Thank you.